Okay. Where are we and where we are heading now? I don't have. So this is my sister's dog, which actually was going to talk on heart failure because patient actually, the dog here has mitral regurgitation, and I'm planning to do a mitral clip whenever I can get a small mitral valve in that patient. Obviously, we always learn from the masters. Here is Alan Kribbier, and I was being honored in India recently at a meeting. So, and I'll skip these slides. I was going to ask all the fellows to name all these people, okay, but I'll skip those slides, okay. So, mitral regurgitation is two types, a primary MR or secondary MR, and mitral valve itself is very complex, contrary to the aortic valve that we talked about. That's why you can just put a balloon and blow it up and you get an excellent result. And whereas with mitral valve is too large, with asymmetric shape, no landmarks, and closing pressures are much higher. So initially I started doing mitral clip in 2009. That's one of our first patients. I actually did mitral clip even before the TAVR. We were part of the Partner 1 trial as well, and but mitral clip was given to us before that. Here is a severe MR, 84-year-old man, deemed inoperable in those days. 2 surgeons have to turn the patient down. Now only 1 surgeon has to turn the patient down. So, so severe MR, 2 hours later, skin to skin, post-clip deployment. It is about 1+ mitral regurgitation seen in this patient. If you can bring down mitral regurgitation from 4+ to 2+, it is considered as a successful procedure in those days, and it is changing now. Now we are trying to go to 1+ or even less. How do you do mitral clip? It is actually based on both the fluoroscopy and transesophageal echo guidance, and using 3D echo is really very helpful. You can look at the 3D mitral valve here, and aortic valve is at 12 o'clock, and mitral valve is right here. And you can see that there is a mitral clip here with the clip arms open. It has to be perpendicular to the mitral coaptation plane. And this is A1 anterior, and A2 is right here, and A3 is on the side. And so similarly, P1, P2, P3. So we place the mitral clip in A2, P2 position, and this mitral clip itself is designed based on Alfieri, who is a surgeon and who used to put a suture in A2, P2 positions. And so this is how it will look after the same day, after the clip is deployed, and you're creating a bi-inlet mitral valve. And so you can look at the gradients in that, and also see the mitral regurgitation coming down very quickly. In case if in the future what we could looking at studies is Carilion mitral contour system. This is an indirect annuloplasty device, because with the tear in the edge-to-edge repair, you're not addressing anything else other than the leaflet tips. So here is a device that actually can go into the coronary sinus, which is very useful because it's right next to the mitral annulus, and you can shrink the coronary sinus and tighten it up so that you are creating an indirect annuloplasty device. And this is how it can be done under fluoroscopy. All our electrophysiologists access the coronary sinus all the time, and sometimes interventional cardiologists, when we do radial cath, sometimes it can automatically, a right heart cath, it can automatically go into that position as well in the coronary sinus. And so reduce FMR in functional mitral regurgitation. The mitral clip has been looked at, the Carilion has been looked at to reduce the primary endpoint, which is a change in regurgitant volume at 1 year, which is statistically significant, and the primary endpoint was met. So that is something that we probably will look. But right now, the FDA approved devices are only mitral clip, which is from Abbott, to try transcatheter edge-to-edge repair. And Pascal from Edwards is coming next into the market as a FDA approved device. The initial trial, which we were part of, is called the Everest 2 study. Everest 1 was a small pilot study. Everest 2 is functional and degenerative mitral valve patients were included, but primarily in degenerative MR, it was approved based on this study that at 5 years, compared to surgery and versus mitral clip, there is no difference in the survival. And in fact, patients who underwent surgery had a little bit more need for blood transfusions, but they had 0 MR predominantly. And whereas in the mitral clip arm, they were about, most of them were mild to moderate MR, 1 to 2+ MR was still detected. But patients always felt better even if it was 1+ MR. So then the next study we enrolled patients in is a COAPT study, which is a functional mitral regurgitation, and looking at a guideline-directed medical therapy alone in people who have ejection fraction less than 50% and heart failure symptoms. So compared to guideline-directed medical therapy, MitraClip plus GDMT actually showed that the reduction in all hospitalizations for heart failure for 24 months. This was very good because a very difficult study to do, because even if you adjust furosemide from 20 milligrams to 40 milligrams, you have to wait for 1 more month before actually randomizing the patient. So up to 5 years, it is still excellent reduction in heart failure, and also death was also lower with guideline-directed medical therapy plus MitraClip rather than just medical therapy alone. And the first heart failure hospitalization is lower with the MitraClip, and this has been shown in the up to 2 years, and after 2 years it actually is not a big difference, And all-cause mortality, there is an absolute reduction of mortality about 10%. So that means you have to do only 10 MitraClips and in functional mitral regurgitation to save 1 patient. So what is the lower limit? You can ask me if we say in the ejection fraction, less than 20, don't do MitraClip. We have studied that. It is on a FDA-approved trial that actually looked at these patients with low ejection fraction. They don't do well even if you do MitraClip. So 20 to 50, you can do a functional mitral regurgitation. Patients can have MitraClip. So what are the negative predictors? Any valve area for degenerative mitral valve less than 3.5 centimeters square, don't do MitraClip. You're going to create mitral stenosis, which is much more dangerous than actually leaving them with even severe MR. So 3.5, the traditional 4. But we can push the envelope after doing some MitraClips up to 3.5. Below 3.5, I will not recommend MitraClip even in our center. Anyone with myxomatous degenerative mitral valve, I'll show it to you. Some of these patients, you cannot do a good service with MitraClip. We get 1 or 2 patients nowadays because we are doing a clinical study, and such as degenerative MR, but if you're truly Barlow's, I would not recommend MitraClip unless. So these are the trials ongoing called Summit trial, where we are comparing MitraClip to actually a transcatheter mitral valve replacement. And the repair MR is comparing surgery to MitraClip in intermediate risk patients, and primary MR, which is NIH funded trial where we are enrolling patients all risk, meaning low, intermediate and high risk patients with primary mitral regurgitation can be enrolled, or degenerative mitral regurgitation can be enrolled either to MitraClip or surgery. At our center, our surgeons are excellent with robotic mitral valve surgery, so many of those patients go towards that if they are not in the trial. So valve-in-valve, this is a 59-year-old woman who had a mitral valve replacement done twice with bioprosthetic valves, and actually had a pinhole mitral valve, and with the there is a regurgitation actually happening because there is a whole perforated leaflet, as you can see there, it's coming in. And so this one was done long time ago with the transapical. Patient improved from class 4 to class 1 within 2 days, and output went from 1 liter to 2.2 liters. Nowadays, the same thing is done valve-in-valves with the transcatheter, transeptal, without needing transapical procedures. And so in patients with who have this myxomatous degenerative valves, you can do Tendyne, which I think is not playing here. Okay, so I'll skip that slide. This is a Tendyne that you can actually go transapical and replace the mitral valve very well in people who have flail gap more than 10 millimeters that you cannot actually treat with the MitraClip in these patients. Here is another 84-year-old woman who also had, sorry that these slides are not playing on this. So you can do transapical or transeptal nowadays with the Intrepid valve that is from Medtronic, which is ongoing actually, and Tendyne is from Abbott, which is only available as a transapical to completely replace the mitral valve. And these patients still have high 30-day mortality, so that's why they're part of still a trial, and we are going to probably have an understanding within a year. And so I'll stop, I think, with that. These patients who undergo Tendyne can also develop alcohol septal, can develop LVOT gradients, so you need to do a CT scan to look at what is the neo-LVOT, the reason for that can cause obstruction to the LVOT, and maybe do an alcohol septal ablation in such patients. So I think in take-home message, if you do mitral clip, obviously it cannot treat all patients. Knowing the anatomy of the mitral valve helps in choosing the right therapy. Summit trial will show whether mitral clip or Tendyne is better, and primary MR will show whether surgery versus mitral clip is going to be better. Thank you very much.